Good day and welcome to what we know will be an informative discussion about esophageal cancer. My name is Phil Alongi and I will be your moderator for this discussion. Joining me is Bart Frasita, founder of Esophageal Cancer Education Foundation, or better known as ECEF, and a 26-year esophageal cancer survivor and sponsor of this event. Welcome, Bart.
You're welcome. Hello.
Together, we're joined by Dr. Prasad Adusumili, thoracic surgeon and researcher at Memorial Sloan Kettering Cancer Center. His work, supported in part by the Esophageal Cancer Education Foundation, is helping to advance new approaches to treating esophageal cancer. Welcome, Dr. Adusumili, and appreciate you being here with us today, sir.
Thank you. Hello.
Okay, let's get started. We have a lot to cover. For those who may not be familiar with your work, Doctor, can you share your role at Memorial Sloan Kettering and your focus within thoracic oncology?
Thank you. So I'm a thoracic surgeon. What it means is primarily removing any cancers within the chest. That includes esophageal cancer, lung cancer, any metastasis to the lung. In addition, being a surgeon, we have a research lab, about 20 researchers in the lab. That includes MDs, doctors, research scientists, PhDs, research technicians, and we have junior faculty from other countries who come here for research training, focusing on the translational research, studying tumor cancer immunology and immunotherapies. That's our focus. So I do both as a surgeon and a translational researcher, and that's what my primary role at Memorial Sloan Kettering Cancer Center.
Great, that's great. What drew you to specialize in esophageal cancer and thoracic surgery? And because that's a very complex combination, and curious to hear how you knew enough to bring yourself into that.
I think we all get influenced by mentors during our careers and training. I trained both in India, England, and the United States. And I liked cardiothoracic surgery, operating on the heart and the lung, and esophagus and other organs within the chest. The heart, as fascinating as it is, most of the time behaves and mechanical function, but the cancer biology and immunology is complex and very challenging. And one of my mentors used to say, take a problem and focus on this for your lifetime to make a difference. That's where you will be satisfied and others will be satisfied. So that's what influenced me to coming to cancer immunology and immunotherapy, and working with the great mentors at Memorial Sloan Kettering Cancer Center. That solidified over a period of years.
Flipping that around, Bart, what was it that drove you and Ginny into coming up with the idea of starting a foundation?
It was interesting. When I was diagnosed, I had this problem swallowing, is what caused me to ask a doctor's opinion. Went for an endoscope and they said I had cancer. And I said, cancer of what? And he said, the esophagus. And I said, how could you have cancer in a tube? And he said, well, you do. And when he asked me that was I a heartburn patient, I said, I've been a heartburn patient for well over 30 years, all my business career. He said, and that's what led to your esophageal cancer. And the interesting part of that is when we thought about it, Ginny and I thought about it, we said, gee, how many people in this country know that have heartburn, persistent heartburn, don't know that it can lead to esophageal cancer? And we realized there are a lot of people. So we ultimately decided, after about 2 years of working with Dr. Baines and Dr. Adusumili, we decided to form the Esophageal Cancer Education Foundation, one, to bring awareness, to educate the public, but more importantly, to walk the journey with patients that have this disease. And dealing with Dr. Adusumili, Dr. Baines, and the other surgeons at Sloan Kettering, I was able to see a lot of the patients as they were first hearing about the disease, and was helping them basically cope with the unknown that they were about to experience. And it was a 26-year project to do that, and we do that well now. So that's basically what we did.
Doctor, can you walk us through the research you're currently leading and what you're aiming to better understand or improve, sir?
So Patients like Bart, when they come, patients with the early stage cancer, we are able to resect. It's an, as you know, surgical resection, removing the esophagus and combination with chemotherapy radiation. But unfortunately, in this country and anywhere in the world, cancer initially does not give symptoms that get missed and develops into an advanced cancer. What is fascinating is our immune system is so good. Even if a few cells take the wrong route, our immune system will detect and try to get rid of them. For example, I'm allergic to pollen. The moment spring starts, my immune cells realize I'm getting exposed within an hour. I started developing symptoms. So how cancer cell escapes this immune system? Cancer cell is a cell that went rogue, and how it escapes the immune system, what mechanisms it's using, and how can we re-educate the immune system? We learned that immunotherapy, for example, you might have seen on the TV, Keytruda and similar kind of drugs, where if an immune system recognizes cancer but exhausted, we can reinvigorate them, get rid of cancer. And that's working maybe on average 1 in 5 patients. So this is what our lab investigate. First of all, again, thanks to a lot of help and support from ECEF and Bart, we wanted to take the tumors, cancers that are resected, and the lymph nodes, take it to the lab, study them, like what is happening there, how did they develop cancer and how they escaped immune system. And on the other hand, study the blood samples, what's happening in the patient, and develop immunotherapy. I can go deep into that later. And so this kind of two, and then again, thanks again for all the help. Ultimately, we are able to start a clinical trial with CAR T-cell immunotherapy. We are taking the samples back from the patient to the lab. So these are kind of 3 different things we are learning from to advance immunotherapy for esophageal cancer patients.
Every day in the newspaper, you'll be reading various progress that's been made in a foreign country, and the treatment is available and all. We obviously have to go through the FDA here in the United States. Do you consider that an asset or a detriment?
I think any system has its own with FDA, a lot of advantages, and obviously we would like to proceed even faster, both patients and the researchers. But unless you study in a systematic fashion and a good number of patients, the Hippocratic oath is first do no harm. To satisfy that principle, we need to study in detail, understand the rationale mechanism before applying a treatment. And when we apply the treatment, we have to go through the stages, make sure it is safe, we are not hurting, and realistically it's giving good results. And ultimately to see not all the patients are going to get results, so which group of patients are getting results. So that's where the FDA system is very obviously sophisticated, well established, and all the treatments we have it. In other countries, regulatory system is a little bit less restricted. For example, United States, the CAR T-cell therapy we are doing, we need to satisfy all the institutional requirement, then go to FDA to start the trial, get FDA permission, then we can start the trial. Whereas in other countries, for example, China, you just need to go to the hospital board, get approval, and you can start a clinical trial. Only when you have results or when you want to expand more than one hospital, that's when you need to go to FDA. So one hand, that looks like can move faster, but on the other hand, any complications or not taking all the regulatory will set you back to 5 years. So both systems have its own merit, but obviously, United States FDA system is well established, and do no harm and identify the patients who get benefit is definitely working. But it's frustrating, both as a researcher and patients. We would like the system to be faster. And people are leadership is looking into how to make that as well now with the competition. So
the process that we have to go through in the United States to get something approved is a long, drawn-out process. And what drove us to support Dr. Adusumili's effort was how clear-cut the direction was and just how he was going to perform what he said he was going to do. Basically taking cancer cells from a body, taking T cells from a body, educating the T cells to overcome the cancer cells, and then re-inject them back into the body so those T cells can fight the remaining cancer, was a clear understanding of the path and where he was going and how he planned to get there. And that was one of the reasons we chose to continue to support Dr. Adusumili in his efforts.
And that support was critical, if I may add, because to do a clinical trial with the regulatory and all the required, you need a lot of support, a lot of funding.
Mm-hmm.
But when you think about it, all the federal funding is our tax money. So they have to be very careful in giving that money. So they need to see initial supportive data, preliminary data. For example, to take the immune cells, what type of immune cells, how are we going to do it? And for immune cells to teach them, we do genetic engineering, how to find the cancer cell, which protein on the cancer cell they should be targeting, and what are the methods to do that. We needed that support, preliminary support, to be able to get funding from the federal government for the clinical trial. And all that support came from ECEF and Bart. So to collect the patient samples, to analyze them, to identify what's the protein to target, and how we should give, what doses to do experiments in the mice. Mm-hmm. Most of the support, it was very critical, because to ask for a large sum of money for the clinical trial without that critical data, which is again our tax money, would have been very difficult. And that's where we appreciate support from the ECEF.
Well, I think esophageal cancer as well as stomach cancer are part of the rare cancer determination. There aren't a lot of cases each year. So the amount of money devoted to that by private institutions is not significant. And that's why the government put forth with the Defense Department a program of looking at rare cancers and seeing if they can provide funding to those individual institutions that have projects focused on esophageal cancer, stomach cancer, and various other rare cancers. And we got involved in that, in being one of the patient advocates on those projects. And although I was not allowed to take on the Memorial Sloan Kettering project, so we got involved in other projects, and it was very interesting the effort the government is putting into trying to get good money put into good projects. So, and it's working.
Great. Doctor, we've touched on the FDA role and how they are good or bad and different references that people make. What are the key challenges in treating esophageal cancer today that your work is trying to address particularly?
Yeah, I think in cancer research, we are advancing much faster this decade compared to the previous decades because of all the technology that is available. We are calling it as esophageal cancer as if it's just one particular cancer, but within esophageal cancer and within each patient, the cancer has multiple subtypes, and within the cancer in the same patient, part of the cancer is behaving one way and part of the cancer, and the immune responses are different. So before to study that, we need to take the cancer, the tumor, we need to cut into slides, put on each slide. Mm-hmm. On each slide, we can only study like maybe one protein or two at the most. But with the advanced technology now, like within the past decade, we can study like 7 proteins, 7 cells on one slide. We thought that is the advancement, and we are excited, and that's what some of the studies we did on esophageal cancer with ECEF and Bart support. But now, on a given slide, we can study hundreds of cells, thousands of proteins, and hundreds of thousands of genes, all on one slide. This is where humanly it's becoming difficult. As exciting as the advancement is, as a human being to study that, it's very difficult. And when we study, it's not how many are there, who is talking to who, which immune cell is talking to which immune cell, why one immune cell is able to attack the cancer cell, but the other one is not. All those. So that's where millions of data, and as you know, in other fields, like even here, the AI, artificial intelligence is helping us. And that's what part of the lab does as well, to develop the algorithms to teach the AI and to simplify that so that we can extract the data quicker than a human being can do what we were used to do. This is in the research setup, but I can foresee in the next 5 years, this will advance to clinical stage. So no longer when a patient comes, we won't say, okay, esophageal cancer. We're going to say multiple characteristics of the cancer, immune system, so that we can choose a very personalized treatment for that patient. And when we combine treatments, chemotherapy, radiation, immunotherapy, surgery, which one should go first? Which one should go later? Just as a simple example, we can train your body immune system while the cancer is there. So that's where we have to take advantage of training the body immune system. So after the cancer is removed, your immune system can keep on patrolling to make sure it's not coming back. So this is where artificial intelligence is helping. Advancing in techniques, we are going much deeper into a cancer cell and within a patient's cancer. And I'm excited like where we're going to be in 5 years from now.
One of the things,
Go ahead, Bart.
one of the things that in talking to patients in our support groups over the 20 odd years that we've been doing it, we realize that patients are unique and different. That what works for one patient will not work for another patient. And when this AI comes in, it can literally create a humongous database of everybody's reactions and then develop what is the best way of handling that. Sloan Kettering, for instance, their drug department, pharmacy department, every time a new drug would come out on the market, they would have to look at that drug and say, what are the negative aspects of that drug and how those drug elements fit in with the drug elements we already have on our existing drug system. And effectively, that would have to be done individually. So one person would take a particular drug, look at all the side effects and say, how are these side effects going to affect the drugs that we now have in our database? Now with AI, that's done instantly and is done across a bunch of drugs at once. So it's literally saving a lot of tax dollars and a lot of corporate dollars in doing the analysis and determining the best way to go forward. So AI has definitely been a major influence on where we're going, where we've been and where we're going.
Yeah, that's
Well,
exactly right. Yeah.
Question to both of you about AI. Obviously, everybody thinks this is like the super answer to many of the questions coming forward. But what concerns do both of you have? First, you, Doctor, with AI about getting out of hand or being misused.
Yeah, I think AI is at the end of the day a tool. As you know, any tool can be used for good purposes and bad purposes. Mm-hmm. So, but the AI tool is dependent upon how much information we feed. And that information we are feeding, we have to be careful as researchers, as scientists and clinicians, what information we are feeding into the system. And that's where what Bart was saying before, Memorial Sloan Kettering Cancer Center, with a wealth of patient data information and with appropriate people screening what information to feed into the system, because we know tomorrow the decisions might be made based on the system. So that's where just like any other system, the quality checks comes into the play and how to use the system and what checkpoints have to be there. So,
I think with every quality system, you're always going to have people looking to infiltrate it and try to benefit from it on their own behalf. So I think we need a strong set of guidelines when it comes to AI involvement and how we use it and where we use it. Because I think out of hand, you can see where something like this can get out of hand and handled by people that have the wrong impression or the wrong thought processes and looking to make money out of it, and can create a tremendous problem for the public. So I think having a good set of guidelines as to what we can do and what we shouldn't do is important to make this go forward.
And at a research level, when we are naming a cell or when we are attributing a character to a particular cell, we are careful by repeatedly testing to make sure the proteins we are telling, the genes we are identifying are indeed what we are saying, that's what it is. Because at the end of the day, even within a given cell, there's a lot of interactions going on, a lot of system pathways going on. So that's where at a research level, we collect the information and it's going to be useful for multiple labs.
Good, yeah.
So the question, though, staying with the AI topic, is that going to free up more money to help in the fight? Or will money be taken away because people think that we have a bunch of computers now that could do the same thing as you do, sir?
I think initially investment, just like Bart invested in our lab for 15 years, the ECEF Foundation. At that time, if you look at the first 5-7 years returns, not much. But today we are able to publish papers on early stage esophageal cancer detection by blood test. We're able to publish on the immune system on the esophageal cancer. And the knowledge helped some other clinical trials that we also published. And now we started this CAR T-cell clinical trial that we treated 8 patients. So I think the same thing probably I would say for the AI. Initially, there will be consumption of resources and developing the system, trial and error. But once it is established, I think it's going to make things faster, efficient, and cost effective. When that is going to be, anybody's guess. So.
Have you seen any impact to funding of research projects because of AI, or is everything status quo right now?
At this point on the research setup, there's no major changes, but obviously there's a lot of encouragement to use the system. And when we supply the data, that's supportive of what we're asking to do it. And there are tools that are being developed to make the research very efficient. If I look back to my training period where I used to go to the library and put my name to photocopy an article to now, where within a fraction of a second, I can get any scientific article anywhere in the world. So similarly, the grant funding, when it comes to, they are collecting a lot of information to make sure to connect the researchers, that we all know what the other person is doing and how to benefit from that. And they're kind of a little bit providing guidelines to do that rather than sitting in silo in the lab and doing our own research. So this is an evolving system, and I think it's ultimately going to benefit. There's going to be some initial birth pains, but hopefully it will help all of us.
Yeah, I think from my point of view, if I'm preparing a speech, I can put into AI just 2 or 3 words about the speech, and it will create my speech for me. And it's amazing how accurate and how precise it is in what it has gathered from its knowledge of, let's say, esophageal cancer, and what it puts into my presentation. And I've had situations where I've done very minor changes to what they produced and have presented that. So it definitely is a plus. The key element is just being careful with who gets to use it and how they get to use it and the guidelines that are established for it.
Bart, we've always referred to ECEF as a blue-collar foundation. So all the money that we earn, all of the money that's given is used in a very wise and respectful way.
Yeah.
Have you seen anything on your side that funding has dropped off or more questions coming up because of AI?
We see a lot more involvement in ECEF, and I'm not sure if it's AI driven or just more advertising, more publicity, more action on our part to get our name out there and what we're doing and how we're helping people. I think the key element is exposure, and AI can give us that exposure. And that's what we, hopefully will drive people to the site, see what we're doing to help people survive this disease and what projects we have on the board and be part of those. And that pure education process will help people have a better life resistance and ability to handle different things in their course of their actions.
Dr. Adusumili, you're known for taking challenges on, and your work has always progressed forward. And look how long you and Bart have worked together on all of these various things. Is there anything in particular that's been a key challenge that you would like to discuss today? Or I'm sure there is one, but what would that be if there is?
Obviously, we all want to progress faster. Patients, looking at the patients and the conditions, we want to progress faster and do more research and collect more information and translate the treatments as well. Funding support is always the issue, but any small funding helps because again, that's what ECEF has done for us in the initial stages. That's definitely always needed and helps us to do more research and move forward. And the second thing is, as difficult it is to have patience, sometimes when we discover something which we did and other research labs do, there's a lot of caution. Unless the discovery is reproduced by somebody else, we don't want to act upon it quickly. So when we discover things in the lab, we get excited. We want the world to quickly understand and accept. But over the period of years, I learned we have to be patient and help others to do the research so that they can cut short the time, so the results get reproduced. When you see results from 2-3 different institutions, labs, then you know there is some underlying fact, and then the information advances very quickly among the surgeons, researchers, clinicians. So that's where I think what ECF is doing is also very helpful. I think what we did research is in the lab and published papers, but Bart and his colleagues at the foundation have taken it, spread over the patients, educated them, gave them hope, showing the new developments, new research, what is going on, which we are not doing that from the research lab. And translating into the language of the families that they can understand, not much scientific word, but this is not an easy job. And that's where we are grateful, very grateful. That information that we are discovering, validating is in real time, reaching the patients, families, and loved ones. So they're supportive, they feel satisfied something is being done, and gives hope. So
That's what basically drove me to Sloan Kettering at the very beginning. Talking to Dr. Baines, who ultimately did my surgery, gave me a confidence level that I had not seen before. And reading about him and reading about Dr. Adusumili and just the overall focus of Sloan Kettering really said, you need to stay involved and get involved with them and do whatever you can do to help them. And we did that as a volunteer and then also as a supporter and of the research projects that Dr. Adusumili is doing, because we have that confidence in the institution and in the individuals who we deal with, and that's what causes us to stay involved with Sloan Kettering.
That's very critical. I mean, Bart mentioned Dr. Baines, obviously, is a godfather who trained us and supported us. Not only that I know I have my back in the operating room, Dr. Baines is around, that's not that, but giving me the peace of mind to be able to do the research. Dr. Baines and other colleagues of mine, they supported the research by letting me do it and taking care of some of the responsibility sharing. And that was very critical for our lab and research to move forward, knowing that I have excellent colleagues that will have my back, and so I can focus my mind on the research. As a clinician, I have the advantage. As a surgeon, I have the advantage. I see the patient in the clinic. I see their tumor in the operating room. I see their cells and genes in the lab. That's really a privilege for me to connect these things. And that's where my colleagues come into play to be able to support me. So
I can say if it wasn't for Dr. Baines, ECEF would be nothing like it is today. It would be a shadow of what it is. And he has taken an interest in it and has helped me expose what we do and how we do it to a greater public of thoracic surgeons. And that's been the basis of the foundation doing what it does. So great kudos to Dr. Baines.
Getting back to the research and also how advances in cancer care with the immunotherapy or the targeted therapies, how much sharing is there among various research groups of work that's ongoing and results that they're getting?
Yeah. On one hand, in the research, when we focus on one molecule, one gene, one cell. And that's what we are doing. And after that, once the research matures and gets published, that's what initially cancer biology, gene sequencing, that's what developed a decade before. The immune system and understanding cancer immunology is past decade. But now things are coming together, combining the genes, biology, and cancer immune system. And researchers are talking about it because it's become essential. Nobody asked before, when we give chemotherapy, what's happening to the body immune system, what's happening to the cancer immune. Similarly, radiation therapy. So now that is, we are talking and we are coordinating, and that's resulting in the treatment. Because in any given patient, unlikely there's only one form of treatment. We are combining surgery, chemotherapy, radiation therapy, immunotherapy, and this is only is possible when clinicians are talking together, researchers are talking together, understanding what is the immune side effects of chemotherapy, what chemotherapy can be combined, when should we give radiation. So before it looks like we are not talking, but until the system matures, it's difficult to get together and make a meaningful combination treatment for the patients, and that's what is happening now. So
Bart said how when he got his diagnosis, how much has it progressed in terms of making diagnoses in this day and age, that this way it doesn't get to the point it did with Bart?
in the research field, we are trying to come up with a blood test and early endoscopies and markers, but we are not there yet. We are far away from it in the sense cancer notoriously try to hide and escape.
Mhm.
It doesn't declare. I mean, I get an infection, I get a pneumonia, it declares by getting a cough and a fever. But cancer doesn't do that, and that's where we miss it. So biomarker studies looking at which group of patients are at high risk, that is well defined for most of the cancers, including esophageal cancer. So the studies are focusing on how can we diagnose this early as a biomarker. And obviously blood test will be simple. That's what everybody wants to. But we are not there yet, and more research need to be done there.
When I was first diagnosed, never heard anything about biomarkers and all of that interesting background as to analyzing the cancer. And I know there's been a tremendous development in the operating room with the cancer, but the other one side of it is that now several institutions are involving a gastro surgeon along with a thoracic surgeon in performing the esophagectomy surgery. So things are improving across not only the way of identifying cancer and what best works against that particular cancer, but the actual operating room procedures and operating room personnel is changing as well. So it's all a focus on getting better, and I think we're doing that.
Okay. Coming back just to families and people that are going to be diagnosed with this disease, what should they know and understand so that they can be a valuable asset to your research and actually even their treatment itself?
Yeah, I think, again, here the internet and AI to helping to a certain extent, because just like Bart, when the diagnosis comes, it's a shock. That is something you never heard of, you never thought of, and you don't know the details. So patients are coming a bit more educated, family members, and I think they should ask questions and ask about the treatment options, and should not shy away from it to a certain extent. That will help clinicians to acquire the knowledge and to answer appropriately. And when you go to the treatment, we uniformly ask all our patients to participate in the research protocols, that can we use their tumor, can we use their blood test, and invariably most of the patients agree for that, and that's been a great help, because when a new discovery comes this year, I was able to pull last 15 years of tumors that we saved and look into esophageal cancer. It may be discovered in some other cancer, but we can look and see if that is appropriate. That's where the translation happens fast, because I don't have to spend that much time what was spent in other cancers. So agreeing for the research and agreeing to use the blood and the tumors has been great help. And so this is the ways they can support. And as Bart said, Department of Defense, we got several funding from Department of Defense. They did a great job. They included patient advocates. Each grant not only reviewed by 2 scientific reviewers, but the one patient advocate, either patient or a family member or a close person who is interested. And now it became a norm. All the federal grants, there are 3 people, 2 scientific reviewers, and 1 patient, family member, or a foundation member to give their perspective about that research project and what they would like to see from the patient point of view. I think that is actually very good both for the clinicians, researchers, and cancer patients, something to keep in mind, how you can help beyond monetary help. So
one of the things that we did early on, Dr. Baines, again, had indicated when I said to him, I want to get involved and help. And he said, one of the things is educating the public about the disease. So he and his staff and myself worked on a book called 100 Questions and Answers About Esophageal Cancer. And it literally took everything aspects from chemo radiation on into the surgery. And subsequently, we realized that people who were going through the surgery were looking at the same situation, not knowing what was going to happen, what could they look at that would give them some guidance. And we created the Esophagectomy Post-Surgical Guidebook Questions and Answers. And we make that available to the public and to institutions. And several institutions have bought significant copies of the book to give to their patients as a way of letting that patient know, here are some of the issues you may experience, but it's good to know all of the issues that we've identified, or at least 100 issues that we've identified that would be helpful to you in identifying what you're going through as you're going through it. And so that's where we're at in our efforts to keep the patient informed, provide these two books, which are a tremendous help to patients.
Well, Bart, what out of the various support groups that we have at ECEF, is there one thing that you can single out that most people come in not knowing enough about how to either respond or make a diagnosis exception?
Well, right now, I think most people we see are in a post-surgery mode where they've been talked to. One of the things I did early on was I volunteered to work with Dr. Baines and seeing his new patients. And as part of that, we had an oncologist that would go in and talk to that patient about the chemo and the radiation they would do. Then Dr. Baines would go in and very graphically demonstrate to that patient the surgery that he was going to do. And then he would say to that patient, we have someone here today who's been through all of this. Would you like to talk to him? And most of them said yes. Some of them were concerned about what I would look like when I walked into the room, but for the most part, they were happy when they saw me. And I would say to that patient, of everything you've heard today, what's the most troubling? And they would say, well, the pain, the cutting, all of that. How much pain am I going to go through? And I would say to them, for the way I handle that, each day, a nurse came into my room and said, rate your pain for me, 0 being no pain, 10 being excruciating pain. Her intent was to get my pain level down to the 4 to 5 level. In order to do, and the reason she wanted to do that is because they wanted me to walk at least a mile every day. They wanted me to do 10 breathing exercises, 10 coughing exercises. And if I were in a lot of pain, I wouldn't have been able to do those things. So when a patient hears that as a reasoning that he's possibly going to be experiencing, he can tolerate that, and he has a better understanding of what's going to happen. So that made his journey a little more clear to him as to what was going to happen. And the same thing with quality of life questions. They would ask the question about quality of life, and I would say, it's 2 years now I'm out of surgery. I said I play golf, 9 holes of golf, probably 2-3 times a week. So we go out to dinner maybe 3 or 4 times a month, and I don't eat everything that's on my plate. I take a lot of doggy bags home. But I said, I'm enjoying life, and I'm enjoying this new normal that I'm developing. And that gave that patient a positive attitude, a positive outlook on what was ahead of him. Okay, I never told him that he was going to be better because of this. I've always only shared my experience and the things that I've experienced in my process. And if they asked a question that I hadn't experienced, I would simply say, I didn't experience that. That's the best thing to do is ask Dr. Baines or Dr. any of the other doctors that you become involved with. So it became a process. And most of the surgeons at Sloan did use me to talk to patients, and we developed an email approach to do it. So it was good. And I think a lot of patients benefited from it.
Looking ahead, where do you see the biggest breakthroughs coming we chatted and we touched on a lot of different points, but being a little more focused, where would you see the biggest development coming in terms of a breakthrough?
I think all this treatment, we are seeing a proportion of patients who are responding and not responding, and that studying their tumors and the factors behind it, we learned a lot. I think with that will also help with the new treatment modalities. I mentioned about CAR T cell therapy. I mean, a couple of decades ago, it would have been a science fiction story that I'm going to send you to blood bank and we're going to take only immune cells from your blood and we're going to send you home and we're going to take it to the lab, do a genetic engineering, expand the cells, give it back to you as a blood transfusion. Now they're going to find cancer and kill it. Looks like a science fiction story, but that's what it is now, and it's approved for leukemia, lymphoma, some other cancers. So I think with advances being faster, we were able to, I think we're going to discover new treatment modalities, one, and second is combination, what combination of treatments we can do. And third, as we discussed before, with the diagnostics improving, I'm optimistic that we can diagnose cancer not only early, but for that particular patient, what's the best treatment? And if some side effects happens, quickly recognize and cut it down. So new treatments and faster modalities and the combination of treatments, I think that's what will change the field.
And if you had to single out a challenge, what is the biggest challenge that still faces you day to day as you go into the research lab?
I think I don't know challenge. I think we are all dedicated for the cause that we are working on, and we like it. So when you like it, it's just educating the next generation. So we
cancer cells don't like you. So let's talk.
Right. So educating the next generation in the sense, cancer cells, the advantage they have is they evolve. They constantly evolve and evolve better than us and faster than us for any treatment and environment. And with all this information, we need to evolve the treatments and do that. And that's where we're trying to move faster and come up with the treatment modalities. But understanding the cancer cell and how flexible and adaptable it has been and what we can do in the treatment in the same fashion, I think is going to be the challenge.
Okay. As I said, I think the key element from a patient's perspective is eliminating the what ifs, if you will. When I was first diagnosed, they had several situations where they say, well, we'll try this particular treatment. If that didn't work, we'll try this treatment or whatnot. And it creates impatience and uncertainty as to how they're going forward. And I think with what's happening now, they're able to do all these various tests pre-surgery or pre-diagnosis or as part of the diagnosis. And that enables them to be more confident in the process and the treatment they're recommending to that patient. So it's not giving the patient a question mark to think about, but rather giving a direction that is fairly clean and very understandable and very supportable.
From the clinician point of view, I'll explain the same thing to the patients. Before there's one chemotherapy, so we start the treatment, but patients get impatient waiting when we keep ordering all the tests, and we tell them that now that we have options, now that we have treatments, it's important to get all the information. It may take a week or two, but I understand their anxiety, but we have multiple treatment options, and that's why we are doing more extensive testing before starting the treatment.
Yeah. Yes.
Okay, before we have to say goodbye, I'd like to give both of you an opportunity to have your final say. Bart, to start with you, to the people that are currently getting diagnosis like this now or living through it, what would you like to say to them based on what the doctor has already pointed out is in progress?
I think the process through esophageal cancer recovery is a journey. It's not a quick fix. The mind that you have in your head that says, I want to do everything I used to do, is not going to happen going forward. You've got to develop what I call a new normal. And it's really getting, in essence, the brain in your stomach to really coordinate with the brain in your head. And until you do that, things will not go very well from a food point of view, or from a living point of view. quality of life point of view. So it's important to have patients be patient in their process and learn by what they do, what they eat, what they drink, how they sleep, and literally find a new normal. And that will make their journey a lot easier.
And to add that to what Bart said, the brain does have influence on your immune system. It's amazing what we see in the lab, how your positive attitude in the brain does have influence on the immune system, even during the treatment. I know, as Bart said, it's not easy, but knowing the fact, it's no longer a myth, it's a fact, will definitely help.
Okay, well, I'll take it over from here just to say thank you to both of you gentlemen. Bart, I want to thank you and everything you do with the foundation. It's been a long time, but we've all seen the benefit of the work. So thank you for that, Bart. And
You're
Dr.
welcome.
Adusumili, I don't know what else to say to you. Your demeanor and the work you've done on behalf of the foundation is appreciated by all of us there. Please continue. We have a lot of faith, and we will keep you in our prayers to help give you further guidance on that.
Thank
And
you.
to everyone that's watching this, I want to thank you for your continued support of ECEF. Your involvement and support help makes this kind of progress possible. To learn more about ECEF or Dr. Adusumili's work, or to find ways to get involved, please visit our website, fightec.org. Thank you very much, gentlemen. Have a great day.